Today on the podcast, we have Dr. Alan Burton. He's the Chief Medical Officer of Abbott Laboratories, a $200 billion company. Previous to that, he was in academia at MD Anderson and was even in private practice. He has a storied career, and we're excited to have him on the pod today. So we're super excited to have Dr. Alan Burton here with us today. So welcome to the podcast.
Thank you so much for having me, Dr. Thompson. It's an honor to be here.
So first off, I'd love to just hear a little bit about your career. As I think most people know from the introduction, you're Chief Medical Officer of Abbott Laboratories. You had a history in academia at MD Anderson, and you've also been in private practice. So tell us a little bit about how you ended up at Abbott Labs.
My journey started really with a stint in private practice after training in subspecialty in pain management, interventional pain management, from an anesthesia background. Started in private practice, moved into an academic role, and in that academic role, I started seeing really unmet needs or patients who are not well treated in spite of all the efforts of the current healthcare tech, the current healthcare system. There were still a tremendous amount of unmet needs, particularly in the area that we'll probably focus on today of interventional pain management. That led me to really start doing more and more research in that academic role, then segueing into another private practice where even in our private practice we started doing more and more clinical research. Again, due to this advent of new technologies coming into the space and that persistent problem of unrelieved chronic pain out there, and just seeing this really firsthand in the trenches, so to speak, with patients. The segue then happened when the opportunity came up to join Abbott as a medical officer in their neuromodulation division, and I really was super excited to move from a practice environment where you could see one patient at a time or perhaps at scale what your whole practice was offering to a group of patients, and then the opportunity to move into a large healthcare company where that footprint and that technology reach just expanded exponentially. And so I took advantage of that, now going on about almost 10 years.
So have you been with the neuromodulation? Well, first off, let's explain what neuromodulation is. Would you mind telling, again, for our audience that don't know, what is neuromodulation?
Absolutely. So neuromodulation is an approach that uses a small implantable device. I actually happen to have a mock-up of one. That currently you might recognize as almost a pacemaker, but instead of a pacemaker for the heart, it's a pacemaker for the nervous system. And there's a couple of small wires that come off of this implanted battery, and they're placed very carefully by the specialist in the right location, often near the spinal cord or near certain nerves coming off the spinal cord, or in one aspect of our business, we actually do brain stimulation for certain neurological disorders. And so then with careful pulsed electrical energy, we're able to alter chronic signals, such as chronic pain signals, and really dampen those down. So it's a kind of a pacemaker for the nervous system.
So that's neuromodulation in general is going to be any type of use of waveform to affect nerves, correct?
Yeah, application of electrical energy to treat chronic unrelieved neurological syndromes.
So you can do it for pain. Obviously, you brought up a pacemaker. One of the reasons why a pacemaker works is that our whole body runs on electrical signals, and when you induce an electrical signal, you can do something like make the heart beat, or in this case, as you said, we're trying to calm pain signals down and give people a lot of relief without any type of drug utilization.
100%. And I think an analogy I've used often with patients, and and also talking to neuroscientists and others, is almost a noise-canceling headset for the nervous system, where you're able to dampen out these irritating signals.
So have you been with neuromodulation at Abbott the whole time?
Yes.
Okay, so what drew you to that department? Obviously, as an interventional pain doctor, there's a lot of different interests and areas that you can focus on. Why neuromodulation?
Yeah, I would say that there's been an explosion in the neuromodulation space in the last 10 years of innovative therapies that have been developed, and it's been an exciting area of research. And what it followed is about a decade of explosion in neuroscience understanding and research. I think in the last 10 to 15 years, there's been a deeper, layered understanding of how the brain and nervous system operates than in all of recorded history prior to that. And this explosive understanding of how the brain operates and how nervous signals in the body are handled, how chronic pain signals occur in the body, has led almost naturally to an understanding of how to treat and how to optimize treatment of those signals, and bring people back to a wellness in their nervous system, and then thereby kind of treating those chronic neurological disorders better. And so that revolution is kind of going on right now, and we're getting more effective therapies than ever were available before. And this has all kind of started about 10 years ago. And I was seeing this in clinical research around that time. And that's where this opportunity to move into a company like Abbott, in fact, move into Abbott neuromodulation, was offered. I just jumped at the opportunity, understanding the kind of point we are in history where all this new innovative technology is coming to fruition right now and helping patients.
So on that topic, like obviously we have a lot of patients that we use Abbott. It's a great company. We get great results. And most patients are super, super happy. We do have patients that sometimes ask when we're recommending this, they say, well, I don't want to just cover up the pain. I want to treat the pain, right? Can you talk to this for a moment? Like diabetic neuropathy, obviously we know is a huge issue in our country. Diabetes is one of the #1 diseases that we have chronically in America. Diabetic neuropathy normally is going to manifest numbness, tingling, can be painful diabetic neuropathy. Treating the pain is important, but those people that have the numbness and tingling along with that, does this help? And if so, like how can we address that question of, I don't want to just cover up the symptom, I want to treat it. What are we seeing in the space?
Yeah, I think it's such an important question that you bring up, and I'll take a step back from it if I might first. Pain has often been looked at as just this irritating signal that something is wrong in the body and that it needs to be fixed. And this often leads people down a path where they go for, let's say that you mentioned diabetic neuropathy, let's mention a bad back or a disc problem in the back, and the patient seeks back surgery and they get a back surgery done and they have residual pain in spite of having a successful surgery. And then sometimes people get repeated back surgeries or repeated procedures. And what happens at some point is the pain, instead of being just a signal that something's wrong, the pain actually becomes a disease in and of itself. The nervous system is, in layman's terms, like a fuse box. There's a short circuit in the nervous system. The nervous system was irritated, damaged. Diabetic neuropathy, the peripheral nerves become injured by persistently high glucose levels in the body, and altered circulation in the very smallest capillaries and the smallest peripheral nerves in the body. And some of that damage, nerves are very quick to damage and very slow to heal. And so this neurological injury or damage that can happen, even when the problem is corrected, the patient gets their diabetes under control, they get their spinal canal straightened out or the disc removed, that neural injury has itself turned into a persistent, let's say, short circuit in the fuse box, and then the patient goes on to have persistent pain. They can't walk properly. This leads to often secondary injury because their gait is altered. Now their sleep is off because they're having painful ongoing irritation, so they become not rested appropriately. Their body's not able to settle down the inflammation inside appropriately. And there's kind of a cascade. They become irritable, often depressed, anxious. They see doctors who say, well, your surgery went perfectly. We don't understand why you're having so much pain. It's all in your head. And when doctors, I would say more in the past than currently, but when they say something like that to a patient, that the pain is all in your head, in fact, that's somewhat correct because the pain is in the nervous system, but it's not imaginary, which is unfortunately the way that the patients often interpret that. It's actually an ongoing persistent neural irritation, and these nerve signals become the disease itself. And so the chronic pain actually becomes a maladaptive way that the nervous system has been irritated and continues to trigger off these signals that then lead to a huge alteration in the patient's life. The patient doesn't sleep well, they're not able to function properly, they often lose their job. Sometimes they're so irritable that they have family problems. They may lose their family in this cascade of events, and they become a very difficult patient to take care of because they're anxious and nervous and a bit angry that their treatments haven't really panned out or helped them. So when patients mention, to circle all the way back around to your original question, are we just covering up the problem instead of fundamentally treating it? I think we're actually, by dampening out these pain signals and altering them through this noise canceling phenomenon, we're actually treating the core disease of chronic pain and bringing the patient back to where their nervous system is operating in a more normal level. The pain dampens out, and it's very interesting to see the patients gradually, and then sometimes not that gradually, come back to life, get back to work, get back to fitness, get back to sleeping properly, get back to good nutrition, regain their vocation, regain their family activities, and it really is exciting when that happens.
I know with our patients, one of the things that we've seen is when those patients do get their pain under control, as you said, they start moving again, they start walking again, and I think that a lot of people don't realize that motion is life for the body, right? If you stop moving, things break down. And 100%. So if you stay in that state where it's too painful to walk, well, you're not going to walk, even if you know it's healthy for you, right? 100%. And so by getting that pain under control, getting them active, getting them moving, a lot of stuff can start to heal again, as you said. In fact, one of the things that I love, while it's not something that we're going to prescribe for, we do see frequently that the numbness, not just the pain goes away, but we're seeing numbness. We're seeing that people, we got a phone call from a patient that was it was fun. Our doctor shared it over one of our meetings, but he said that I had a patient call me today and she was crying. And we said, oh no, like, what's wrong? He said, no, like, we did a spinal cord stim on her, and she was crying because she could feel the cold floor in the bathroom again, and she hadn't felt that in like 5 or 10 years. And so, like I said, well, that's not necessarily why you do the procedure. We're doing it because of pain. We have seen many patients that have reported anecdotally that they've had these other effects. And so whether that's because of the device, or whether that's because they're moving again and getting better circulation, and that circulation's allowing for healing, we don't necessarily know all of the details, but we are seeing things like that, which I think when patients are considering this, the most important thing is, as you said, we're trying to go, hey, can we treat that chronic pain? And if we can treat that and get that under control, there's so many other secondary side effects that we can really work on. So with that then, there's another thing that Abbott does that's really unique. Nobody else has this technology. And it's called DRG. One of our doctors absolutely loves it. He talks about it all the time. Can we kind of talk about so DRG is a type of neuromodulation, but what is DRG and why is it different than spinal cord stimulation?
Sure. And again, I love the way that you set that up, that neuromodulation describes the approach, the application of electrical energy to the nervous system to dampen out pain signals. We covered what we call spinal cord stimulation, the main phone line to the brain and stimulating that area. And now the DRG stimulation actually describes where the nerve roots come out of the spinal cord and go down to the legs or the body, trunk, or the arms along the spinal cord. There's a little structure called the dorsal root ganglion, or DRG, on each of those nerves. And that little bump of nerve body near where the spinal nerve plugs into the spinal cord is actually a center of great interest in neuroscience. And in the last 10 years, it turns out that when the patients have a devastating injury to a part of their body, let's say that the patient gets an terrible injury to their knee, or they develop a chronic repetitive injury to their knee, or a knee replacement that's gone bad, or a traumatic injury to their extremity. The nerve that feeds that sensation into the spinal cord, as that pain becomes chronic, lasting more than 6 months, in some cases more than a year, 2 years, 10 years of chronic pain, much of that pain is no longer really located in the knee, but a lot of the nervous activity for that is now in that little structure called the DRG. And that little structure almost serves as a fuse box, or a fuse connecting the peripheral sensory nerve to the spinal cord. And a lot of the pain that the patient feels in their knee is actually electrical signaling going on in that dorsal root ganglion. So when your partner applies the DRG lead right over the specific nerve feeding that area of the body and activates just a very micro amount of energy, the activity, instead of being erratic and being jumbled and confusing the electrical activity in that DRG, in fact normalizes and goes back to feeding normal sensations in. The painful signals dampen out, the normal sensation recurs, and the patients with more even with DRG stimulation, you mentioned this with spinal cord stimulation, a lot of the patients mention in very clearly, as you described a minute ago, my pain's better, but also my leg feels more like my old leg. It feels normal again. I feel hot and cold. I feel where it is. And it hasn't felt that way in a long time. And people that don't have chronic pain, which luckily is maybe most of us, maybe about 20% of people have chronic pain, most of us don't. The closest thing that people feel with these nerve injuries is if you've ever been to the dentist and had an application of local anesthetic for tooth work, and that the odd feelings that you get as it goes to sleep or when it wakes up, and it feels numb, but it feels like it's a different size, or like it's not your face, or these peculiar feelings. People with a chronic nerve injury pain often feel that for years. These abnormal sensations, not only pain, but also hot and cold sensations. Light touch may feel electrical or sharp or like a stabbing sensation. One of the worst things that people feel, they call it allodynia scientifically, where you take a cotton swab and brush it over the area that's injured, and to the patient it often feels like a blowtorch, even though it's just a light touch of a cotton swab. So with a DRG stimulator in place for the right patient, or a spinal cord stimulator in place, the patient again feels the light touch of a cotton swab, or this
without it causing extreme pain.
Without extreme pain, and neuroscientifically, these exact sensory nerve fibers and the way that they fire in through the dorsal root ganglion and into the spinal cord and into the brain, triggering sensation. I once heard a neuroscientist elegantly describe this as a symphonic activity of sensation, that people feel light touch, they feel nuances of temperature regulation, they feel the delight of a light stroking, how that feels pleasant, and there's just a lot to the way that the nervous system operates normally, and when that goes awry, or when it gets injured or becomes pathological, the patient develops chronic pain, it can create a huge amount of mischief and terrible sensations for the patient.
So DRG is primarily for the use of treating chronic regional pain syndrome, right?
That's right.
And so what we've seen in our patient base is very frequently, the one that you brought up is knee surgery, right? They got a knee replacement. The knee replacement was successful. It was good, nothing wrong, but you still have that chronic pain. Or maybe some of the nerves were damaged while they were doing that. Like the procedure went well, but they had to cut through tissue, and when they cut through tissue, sometimes those nerves don't heal properly. Those get chronically inflamed, causing pain, and then we see that. We've seen incredible results where we go and do this procedure, and they're like, my knee feels better again. They're like, I didn't even have to get surgery on my knee, and they ask, how is that possible that you did something on my back and my knee got better? And I think a lot of people don't realize, like, to our knowledge, and I say that with connotation because we're always learning more about the body, but to our knowledge, every single pain signal, no matter where it's at in the body, has to go through the spinal cord and up to the brain.
That's right.
Right? And so the spine actually has massive control over what you're going to feel. The spinal cord does. And so being able to do these procedures in a very real way, you've tried everything, you still have the pain, this can be a really great alternative to possibly continuing with medications. And I say that because we had a case that was presented to us just the other day. Patient had I think 2 or 3 back surgeries. They tried spinal cord stimulation, it didn't work. They tried all these different surgeries, everything. Finally came in, got a DRG, and the patient got, I think, their 6-month follow-up, and they were getting like 80% relief, right? After trying multiple back surgeries, all sorts of medications, and what's even better is that person's now fully off of pain pills completely, off of all medication, and that pain's down about 80%. So again, this is what I love, is I think the future of healthcare, specifically in interventional pain, is not about creating better and better drugs to mask symptoms, although medications do have a place in healthcare and they're very important. I think the future of healthcare is really looking at how can we treat the root cause, how can we understand the body better and adapt systems that the body uses to be able to help people to get active, get them moving, and to be able to ultimately restore function.
I agree with everything you said. I'd like to pull in that thread a little bit about medications, because I think there's something really important on the way that you frame that. Somebody watching this podcast, we're not suggesting, and I know you're not suggesting, that everybody with knee pain needs to go in and get a DRG stimulator.
Correct.
But patients who have a knee pain or back pain or another chronic pain signal, starting with you and your colleagues is a terrific place to start and get a diagnosis and make sure there's nothing correctable.
Yeah.
They don't need another surgical corrective meniscal tear, something fixed that's fixable. Most of our patients who end up with these devices have had attempts at diagnosis and fixing the problem. When that fails or when it falls short of the desired goal, then medications are very appropriate in limited amounts and for specific goals. But I think we're really increasingly aware in the kind of post-opioid crisis world where we've had a real problem with overuse of opioids and addiction, dependence, overdoses, and now a more judicious maybe application of those medications. We're in I would say, a safer place with opioids. They have a role, but it's for limited dose, limited time periods, and with caution that there's a downside to medication management. But certainly people that respond to medications and are able to really improve and rehabilitate and get through physical therapy, get their life back, keep moving, as you said, was the cornerstone, then they don't need an implantable device. But I believe that we're more aware than we have ever of the downside of chronic medication use.
Yep.
And we mentioned opioids. There's breaking news, and I think I just saw a story in the last couple of days on the potential harm of long-term gabapentin use, which previously we thought, well, compared to opioids, that's certainly a safe anti-nerve pain medication.
Yeah.
However, now that we're seeing association potentially with things like confusion, dementia, and other psychological and psychiatric symptoms of long-term gabapentin use, which is interesting. And so we have to be very careful and judicious with our medication use. And where it's helping, it's fine. But often it's just applied because there's sort of nothing else to do for the patient. And I would encourage patients themselves to seek alternatives, to seek expert care, as you and your colleagues offer. And often that comes through seeking through their primary care or through their own work on the internet, watching podcasts like this, to really seek out specialty care, because there are new offerings. And neuromodulation, which we've been talking a lot about, has really evolved a lot. People that say, oh, well, I heard about a spinal cord stimulator in 1995 and it didn't work very well, or those things don't work. I encourage them to look at today's literature and the literature today, where we've had really a renaissance and have terrific outcome studies, evidence-based approaches, new ways of talking to the nervous system electrically that really, I think, have a role to play in treating these chronic syndromes.
And I definitely want to talk more about that, but before we do, like the gabapentin that you brought up, this is a really interesting one because we do a lot of community education. We go out into the community, we hold events, and we try to do everything we can to educate, because we believe that education is one of the most powerful things you can do to change behavior. And if people are sitting there suffering in silence because they don't know that there's options, we're trying to fix that by going on to education. It's one of the reasons we do the podcast, is trying to get good information out to people. But we had this sweet elderly lady come in, and she had very bad, painful diabetic neuropathy. And one of the things she said is, when she came in, was, hey, are you on any type of medications, or have you been prescribed any medications for this? And she said, well, I was on gabapentin, but I stopped. And we asked, like, why did you end up stop taking it? And people say things like, I didn't feel like myself, or it didn't work, or there's a lot of different reasons. But to the part about the confusion, especially at high dosage, this was an interesting one. She said, well, I was at a stoplight, and there was a person crossing, and I felt like I should hit them. And she's like, and all of a sudden I realized, that's not me. And so she's like, and I had just started on the medication, I felt that way, and I've never taken it again. I'm not saying it makes people feel that way, but that's a perfect example of, there are many patients that take gabapentin that don't feel like themselves. They can feel confusion, they can feel those things, and they have to make a choice between, do I take this pill to help with my pain and feel in a way that I don't want to, or do I live with pain? And I think that's one of the most beautiful things about what we're saying, is that's not your only two options. There are other options available.
Exactly.
You need to go out, speak to someone. Don't just go, well, that didn't work for me, I have no options. No, you need to go back to your doctor and say, hey, this is how it made me feel. Are there other things we can do? Because there's more and more options for patients. As medicine gets better, as technology gets better, you don't have to live with pain. There are ways to help.
Yeah, I mean, I echo everything you said is spot on. I think it's, I also think it's very interesting with the the increasing sophistication of the internet, the increasing availability. Your elderly patient now is likely to have a smartphone. While she's waiting for your appointment, she's on surfing her diagnosis and looking up treatment options, right, through AI-based surfing, and so there's more information available to the consumer. But what I encourage people is still you can't DIY this.
Yes.
People get trapped where they feel like they're out of options, and they haven't talked to an expert, and they haven't been, and the experts understand the nuances and how to apply physical therapy, how to take somebody from being virtually immobile with chronic pain and get them back functioning, back to their life, back to driving a car, back to walking, back to
Let me ask you on this one. So we hear sometimes from patients, they go, well, how come my primary care's never talked to me about this? Why is it that, in your opinion, that primary care doctors, who are great doctors and they're doing, they're well educated, they're smart, they're good doctors, why is it that some of them don't know about neuromodulation?
It's a great question. They need to watch your podcast, I think.
It's a good option.
I think that primary care, I think, is more demanding than ever. I think there's so many technological advancements in all fields of medicine that I think it's hard for primary care doctors to keep abreast of all the developments, and I think that's a huge challenge. I don't envy them. I think they have a very, very hard role, as you said, and they're committed and dedicated, and I do think that also managing pain, some doctors unfortunately believe that is a veiled conversation about applying opioids or putting patients on controlled medications. And I think unfortunately that shadow is still lingering around the specialty of pain management, and even though pain management has really kind of helped drive the coming out of the opioid epidemic, and really how to use opioids very sparingly, or very, very judiciously, or almost not at all in some of these patients.
How do we change that stigma of people? They go, oh, you're a pain clinic, you must just treat patients with medications. Like, how do we change that stigma to where not just the general populace, but even among our colleagues as other doctors, that they go, well, I don't want to refer someone over there because they're going to give them medication, where we can educate on the alternative options they have? I
think education around the disease, but I also think there's something with, you mentioned education, which I love. There's always room for more education. One thing with chronic pain, there's a bit of a stigma associated with chronic pain that's always been there, that because it's a little bit of an invisible illness, there's not, if somebody gets
they're not bleeding,
they're not bleeding, they don't have a broken bone, they don't have a cancer, cancers get ribbons, people have fundraisers, there are parade walks. There's not as much of that for chronic pain. It's often like, well, Joe's always been a little lazy, or he's not able to get off the couch. He kind of likes the couch, or there's always a little bit of, if they just had a little tougher constitution, maybe they could gut through it.
Right?
Yeah, and that's unfortunate, but I think it changes through education. And they say until people have a family member with chronic pain, or themselves have experienced some chronic pain, people have a hard time understanding that. I do think we all, with increased awareness that this is a problem, we're able to combat it. I think Abbott's done a really nice job in our diabetes division. We've had a really big ad program and a educational program around the stigma that often accompanies diabetes, and particularly type 2 diabetes, that people just aren't taking care of themselves, or they overeat, or they're slothful, or whatever. And I think they've done a really nice job at first identifying that, and then challenging people's assumptions that type 2 diabetics, half of them have a normal BMI, and it's a genetic problem, and it's not a self-induced condition. And similarly with chronic pain, that this is a neurological condition that can be treated, and and there's lots of effective evidence-based ways to treat it, and it's very legitimate and real. Well, many patients find it incredibly helpful when you, as an expert, on a first appointment, just validate, oh, you're having chronic pain. Just validate. That must be very difficult to live with. And sometimes the patients will break into tears that they've never had a doctor be nice to them before, or show empathy to them about that condition. So.
Well, To your point, I believe one of the big issues with chronic pain is the subject nature of it, right? Pain is felt differently by everyone. So one person's 10 might be another one's 5, and it's one person's 2 might be another one's 8. And so when we hear that, we're going to interpret it through our own lens. When we see somebody in pain and they go, "Oh, I'm in so much pain," it's like, well, I handle pain really well, so you're just weak, right? And so I love the point that you bring out, which is the subject nature of pain makes it to where people don't show the same type of sympathy that they would for cancer. Cancer, oh my goodness, how can I help? How can I be there for you? How can I support? Do you want us to bring you meals? There's a sympathy for good reason, but I mean, if somebody can't move because they're in so much pain, they could use somebody bringing them a meal. They could use some help from friends and family and stuff like that. And unfortunately, in an acute situation, you're in an accident, we see that. But in a chronic situation, it's like, okay, well, how long is this going to last? You've been this way for the last couple of years. When are you going to get back to work? It sounds like what you're saying is that there's a PR issue here. We need to do a better job at helping people to understand the community, that pain is real, that when people experience it, it can absolutely be debilitating. And when somebody experiences chronic pain, that 20% you talked about of the population that experience that it's real, but also I think the next part of it is we can't just validate, it also is, and there's solutions.
That's right.
Right?
That's right.
It's not just that this is going to be that way forever, and I think that some people get into a place where they lose hope. I've been this way for 3 years, I've been this way for 5 years, nobody's helped me, I guess I'm going to have to live the rest of my life this way.
I 100% agree, and I think time is there's some interesting historical elements to where we are today, and I think you've hit on a number of them. Education is super important in this regard, and I believe that the first organized acknowledgement of chronic pain as a specialty happened in the late 1990s, around 1996, where there were board certifications that began to be offered for interventional pain management. And so that's about 100 years later than a specialty like oncology or cardiology or other disciplines. It's a new kid on the block. Having effective treatments that are not related to opioids or addictive medications, meaning the new generation of neurostimulators, for example, have been around now for maybe about 10 years. And so we have the right coalescence of specialists and newer technologies that are evidence-based. And part of our studies, old studies, when I started in this space, late 90s, studies assessed patients' pain score, like you mentioned, a subjective 1 pain number, and then, oh, your pain number is better. Good, okay, that's a good treatment. Now we assess the patient in a very comprehensive way. What's their function? Are they able to walk?
Can they
sleep? Are they able to work? And we assess their psychological status very deeply. And so when we look at a patient and we say, hey, our therapies are effective, we understand that we get 80, 90% pain relief, but we also improve them from moderate to severe disability to mild or almost no disability, where they're able to climb the flight of stairs, they're able to lift a heavy object, they're able to work, they're able to sleep through the night. And psychologically, they no longer have intrusive or depressive thoughts. They're able to get back to activities that they enjoy. They're not ruminating on the pain, or they're not catastrophizing. And so we've really measured our impact, not only on treating the pain, but on treating the entire patient and bringing them back to wellness. And one of the things that first attracted me into Abbott as a 130 plus year global healthcare leader is they have an ethos about life to the fullest, and about, for each person, that's contextual. That's different for an 80-year-old than it is for a 30-year-old with a terrible knee problem, or an 80-year-old with a back problem, or look at our cardiovascular division or diabetes division. These are contextual, but for each person to look at their unique situation and figure out how can we optimize their life. We may not get them to running a marathon, but we may get them to being able to walk their dog, or play with their grandkids, or get back to church, or go back to work.
I mean, at company here, Arizona Pain, the mission statement is to educate and inspire people so they can live a pain-free and active life. And it's that active life part that you're talking about. When you treat pain properly, and you're treating it at its root cause, you're able to give people back to their communities.
That's right.
And I think that that's one of the most beautiful things that pain groups can do, is when it's done well, and when you listen to your patient and you think deeply about how can we treat and help this patient accomplish their goals. That's when you see, hey, I felt listened to, someone validated me, like you said earlier, and then they put out goals that matched my goals. We worked towards those, and ultimately now I'm back to work. Now I can go on walks in the morning with my friends or my family, right? Those types of things is what makes what we do really, really important. Now, one of the things you mentioned that I want to bring up now, you said the new generation of spinal cord stimulators. So Abbott as a company, obviously, they're leading the charge on a lot of really incredible technology and advancements, both in pain and in other spaces in healthcare, which is fantastic. Last night you told me a really cool story while we were at dinner about how some of the new stim wave technology is actually being done to help patients. And you mentioned a story about that comes from Spain. Could you tell us that story again, how burst technology came about?
Yeah, absolutely. It'd be a pleasure. So our, I would say really our crown jewel of our neuromodulation division in Abbott is called burst DR spinal cord stimulation. And the DR refers to a form of spinal stimulation called a de-Ritter burst, or bursted stimulation. The de-Ritter, or the burst DR, de-Ritter is the name of the physician who actually invented and came up with this certain patented waveform that we apply through our devices. And Dirk de Ritter is a European functional neurosurgeon, very clever neurosurgeon and neuroscientist, MD, PhD, and he was doing neuroscientist research on trying to dampen out aberrant nerve signals, not pain signals. He was working on tinnitus, ringing in the ears, in the around 2005, 2006, and his research led him to look at intrinsic signals in the brain and try to figure out how can we use signals that are already in the brain and apply them to various areas and see what kind of effects we get. His inspiration for looking for signals in the body to harness and use the language of the nervous system came from Spain. He was a registrar late in his training of neurosurgery, a prolonged training course. And he was visiting a cathedral in Barcelona called the Sagrada Familia.
By Gaudi, yeah.
And which was Antoni Gaudi's masterpiece. And Gaudi, as an architect, had an ethos that was the architect of the future will mimic nature and find there's no way to improve on nature. That nature has the best patterns, the best approach to problems. And Dirk, while he was in the Sagrada, had this inspiration, saw the Gaudi quote and said, well, why are we looking for higher frequencies or various ways to use electricity? Why don't we really carefully look at the body and see what kind of electrical signals are in the body
Naturally.
And then mimic those and try to reproduce those. And so that set him on a path to try to harness this bursted signal that he was reading and seeing in his neuroscience work in the brain. And he then applied bursted stimulation, a form of what we use today, which we call burst DR stimulation. And he first applied it in patients with ringing in the ears and found he could dampen that ringing. And then, this is now around 15, 16 years ago, they applied it in the first set of chronic pain patients in Europe, 10 patients, and those patients all had fairly impressive relief of their symptoms. And he thought, we're onto something. And this led him to further work that he did, a number of clinical studies, filing a number of patents, presenting his results at scientific congresses, and eventually working with Abbott, who then licensed his technology, brought it through another rigorous clinical study program, FDA approval, global approval, and brought it into the marketplace, where now it's in well over hundreds of thousands of patients over the last decade, and provides spectacular pain relief. But in addition to the pain relief we see with this particular signal, burst DR stimulation, we also see a terrific impact on the patient's psychological status. And when this bursted waveform arrives at the thalamus in the brain from the spinal cord stimulator, the little device that we talked about earlier, it not only dampens out the noise canceling effect on the pain signals, but it also dampens out an area in the brain that called the anterior cingulate cortex, which is a region of the brain in chronic pain patients that is where that is a part of the brain that brings your attention repeatedly to problematic issues. It's a center in the brain
For concentration.
where for concentration, for emotions, for anxiety, for rumination, depression. And in chronic pain patients, this area of the brain repeatedly pulls, how is the pain now? Oh, my pain's getting worse, my pain's getting better, my pain's limiting me, my
It's
pain's
constantly at their attention.
It's constantly has their attention. And so they document their pain. They have pain diaries. Every 2 hours they're filling this out. And what we have found, and Dirk de Ritter found initially with his initial studies, and we've proven it now over and over in a rigorous course of elegant evidence-based, which now creates evidence-based medicine, and we see it in patients every day, is it not only does their pain go away, but they find that their focus is no longer on the pain, that they're able to bring their focus back to life, and their pain is no longer intrusive in their thoughts and in all parts of their life, and it's very liberating. So it's a really amazing electrical paradigm that we have and embrace and have used at Abbott as our spinal cord stimulation approach, and it really fits the ethos of trying to take these patients who are profoundly disabled due to this pain syndrome and not only alleviate their pain, but really bring them back holistically, as you mentioned, to life. And so get them back to fully psychologically being present and being aware of their surroundings, fully engaged with their family, with their life, with their all the activities, and really just enhances their ability to recapture what they've lost through their journey into chronic pain.
I think that's absolutely wonderful how this all came to be, and that story is fantastic, so I really appreciate you sharing that. But I think one of the most common misconceptions that people have, that we at least hear, and we're out doing this community education, is, I heard about somebody who had a spinal cord stim and it didn't work for them. And so, how long ago? It was like 10 years ago, 15 years ago. And what people don't realize is sometimes they see the phone in their pocket change shapes over the last 10, 20 years. It's gotten a bit smaller, then it got bigger, but it got the ability to do more and more things. They essentially have this computer in their pocket that they walk around with, and nobody even thinks twice about it. But how that increase in technology is translated into the healthcare field, I think, is really important. The technology we're using now is not the same as 20 years ago. And so spinal cord stim, if there's somebody out there that's tried spinal cord stim in the past and it didn't work for them, or they've heard about somebody that's tried it and didn't work for them, it's really important to take another look. I think seeing the advancement in technology, talking to a specialist who really does this frequently, not someone that does it every once in a while, but like this is their expertise, you may be surprised that there may be other options that you didn't know because of how this technology advanced. And I love that Abbott's leading the way with that, of really trying to say, how can we bring new types of waveforms, how can we bring new processes to a technology that's existed for a long time, spinal cord stimulation. How can we make it better? How can we improve it? How can we make it smaller? How can we make it less discrete? How can we make the pocket pain less? Like all of those things that you're doing, I think, are so awesome because it pushes our field forward and is really helping a lot of patients. So I just love that story, how you brought that up, so thank you.
Thank you. Terrific cap on the story. I like how you summarized that.
So one of the things, everybody's familiar with Elon Musk. I'm going to change kind of gears on you for a moment. So we're talking about advancements in technology, and there is no one that's really maybe pushing the envelope more in a public setting than Elon Musk, right? He's trying to go to Mars, and the type of technology that you have to do to try to get there, you have to advance us way beyond where we're at now. But one of the things that he's created is their robot systems. And one of the things that he said in a podcast about a week ago was that their Optimus robot, they feel like, is going to be able to be as good as any surgeon within 3 years, 4 years tops, right? And when he said that, I really was like, wow, like I don't know about that. But then I started thinking about the implications of if you really could make the technical component of surgery that good from a robot, what would that do to healthcare? What would that do to the doctor-patient relationship? How does that look in the future? So I'd love to hear, from someone who's works for one of the companies that's at the bleeding edge of health tech, who's pushing technology forward in a good way. What do you think about this? And one, is that possible? And then two, What does the doctor of the future look like in a setting that we have AI and robots and everything like that?
Fantastic question, and I have to say that Abbott Global is headquartered in Chicago, but Abbott Neuromodulation is actually headquartered in Austin, and so there are Elon sightings around Austin, and some of Elon's companies are in Austin. So there's a bit of elbow brushing, with Elon and some of those companies with our headquarters and some of our people. Our technical expertise, our digital program across Abbott, across all of our medical devices, we're very focused on the patient's experience, and there's several guiding principles that we want each technology we develop has to have bring the technology to the next level. We either lead or are at co-leadership in almost every area that we are involved in Abbott, and as we advance technologies, they need to be patient-centric. They need to work in the patient's life and fit the patient rather than the patient having to fit the therapy. A lot of that is naturally involving technology and remote care. A couple of years ago, our CEO had to give a keynote speech, maybe 2 years ago, at the Consumer Electronics Show, and his ethos he talked about was decentralization of healthcare, digitalization of healthcare, and democratization of healthcare as trends.
Yeah.
Abbott has a 2030 sustainability goal to impact about a third of people on the planet, about 3 billion lives directly with our therapies. We think we're on pace to hit that.
That's incredible.
And so our technology has to be cost effective, available to patients, and again, centered around the patient. So our tech teams are creating background infrastructure to gradually and safely involve AI.
Mm-hmm.
We believe that the physician of the future who will lead will be physicians that embrace technology and that work with AI. We don't believe AI will replace physicians, but physicians that are using AI or capable of AI will replace physicians that aren't using it or aren't embracing it. So we are extremely advanced in our tech. We're at the front edge. Patient safety is paramount above all else. Then the patient experience, our outcomes, our ability to scale. And with technology, we're able to, again, using those principles of decentralization and digitization, we're able to capture and ensure good patient outcomes at a scale previously that's not possible, where each outcome needs to be the patient sitting in front of you, talking to you, and you're writing down their outcome. We can do that in a smarter, digitally scaled way that allows more efficiency across the system, thereby bringing the cost down and allowing the therapies to be applied more broadly. So conceptually, I think we're aligned with where Elon's heading, but we're not ready to replace surgeons or doctors yet with his Optimus robots.
Yeah, I mean, I look at that, and obviously I say, I believe that there will always be a place, no matter what, for people to deal with people. I think the more that we see advancements in robotics and technology, the more that we can value relationships. Because if technology and robotics can do a lot of manual things, well, what's left is that person-to-person relationship that can't be recreated, although some are trying with robotics. But I think the point being here is that it's really important that we look at, do we spend time with patients? Do we listen? Do we develop a relationship of trust? And to me, that's going to be the biggest differentiator. In fact, I believe that in a world where robotics can do the technical aspect of surgery, that people will pay a premium to be able to be in front of a human that will listen and work with them. And so while I love the idea that robotics could solve some of the discrepancies that we have between first world and third world countries. I mean, the idea that we could put a robot in any village in the world and they could have access to some of the most advanced surgeries and processes out there for cheap, that's incredible. And being able to raise maybe the health of the world on a global scale robotics could be a great gateway to that. I don't know, we'll see, right? But it could be. But I do think that in a world of robotics, person-to-person relationships will become more and more valuable.
Extremely well said. I couldn't have said it better. I think one of the Abbott ethos is aligned with, high tech and high touch are not mutually exclusive. We think you can have and deserve both, and the best of both.
So, I love that phrase. How does that work in practice?
I think how it works is that we're very that we have expertise in all the right areas of tech to avail to contextualize therapy of chronic illness, which historically has been not very effective, been very labor intensive, and extremely hard to access, burdensome on the patient, burdensome on the healthcare system, and really apply our technological solutions where those gaps exist and where those opportunities exist. So bring technology in very carefully and at those nodal points of pain points to allow patients to really ease the burden on the healthcare system, including the physicians and the patients. I'll give you an example of this. We've applied a remote programming solution where we're able to, through our implanted devices, through a careful FDA pathway, cyber secure, respecting patient privacy, with clear opt-outs, opt-ins, et cetera, set up a solution, a virtual clinic, where a patient can have a FaceTime call with their doctor remotely and have their implanted device readjusted or troubleshooting or reprogrammed. And this is let's say this is we'll use a baseball analogy, like a 9-inning game of health tech. We're probably in the first or second inning of applying these technologies broadly and out into the field. But what we found, the areas of adoption for this are very interesting. We found 2 areas where this is adopted. The obvious one is rural areas. We have patients let's say in Michigan, who live in the Upper Peninsula, who have to come to Michigan or Detroit 6 hours away to get their brain stimulator adjusted. It's really hard for an elderly patient with Parkinson's in the winter to make a 6-hour drive down. When those patients can have a remote visit and have their device adjusted, it's opened a world of patients access to a therapy they wouldn't otherwise have. So we see that in, let's say, that area, Canada and British Columbia. There's patients who come in from the northwest provinces into British Columbia. Massive travel involved in that. There's a guy in northern Sweden who has patients come in from near the Arctic Circle to see him, and have to take 2-day trip to get in for a clinic visit. But if they have a Wi-Fi connection, they can be taken care of remotely.
I think that's an incredible example of high tech and high touch being done together and not mutually exclusive.
100%. The surprising area we found this having uptake is in crowded urban areas. New York City, Paris. It's every bit as difficult for an 80-year-old to navigate a 6-hour trip in northern Sweden as it is for somebody to make a 3-hour trip across from the Bronx into Manhattan, with public transit or driving or even Ubering and parking and navigating all the complexities. This is.
I really do think you're onto something here of how technology can actually improve access. And by improving access, we see compliance go up. And if we see compliance go up, we see health scores go up, right? So this is a really great area of conversation. But one of the things that I wonder is, will health insurance companies keep up with that type of innovation, right? One of the biggest issues is affordability of care, right? And insurance helps to supplement that. There's a lot of people that have concerns about insurance, especially around affordability right now. It's a real issue. But you see these advancements in technology. Technology is speeding up. We're not slowing down. Like some of the leaps and bounds, AI, I feel like only is going to make technology accelerate faster, and the things that we can do with technology. A lot of doctors want to implement those. A lot of patients want to implement those. They want to use technology to have access to education, access to the doctor, access to medications, access to treatment, whatever it is. Big companies like health insurance companies don't move as fast as the advancements of technology. So how can we make sure that while we're seeing these great advancements in technology that can change patients' lives, can also be accessible to patients that need it most?
Yeah, terrific question. Earlier I was talking about the criteria as we at Abbott vet new technologies or look at our new future directions, places we're headed. New technologies, as we're vetting them and as we're figuring out a way to bring them in and develop them and apply them, they have to be cost effective. Today that is table stakes. It is something that's super effective but has a 5x, 3x, 10x cost over current existing treatments today is a non-starter. It has to be at or below current costs looking forward. And we believe that part of the advent of incorporating all the technology we've talked about with AI, with remote care, with digital advancements, part of the ability to scale those is taking advantage of the cost effectiveness aspect of that and lowering the cost to the system. And really, we feel that it's part of our mission is to work with health authorities around the globe, in the U.S., a lot of our healthcare companies around most of the globe, including the U.S. A lot of it involves governmental payers, Medicare in the U.S., Medicaid. In most other external countries, it's governmental payment. And really, for our technologies to get on their formulary, they have to be cost effective, meaning that for the same disease state, a new treatment that's being introduced or being upgraded has to be at the same or lower cost than what it's replacing. And so we think that's our future.
I do think
healthcare is a zero-sum game. We have to get more efficient at it.
I do think that technology can lower cost. But there's a difference between lower cost and coverage. And is Abbott doing anything to try to help from a coverage perspective of these types of procedures? Like, what do you guys do to work, whether it's with the government, with the VA, with health insurance companies, to try to create accessibility of this type of product and technology?
Yeah, Abbott, similar to I think most large health companies, but Abbott particularly has a very large dedicated force in governmental affairs, also in health economics and reimbursement, payer experts that work closely with all the commercial insurance companies. We're part of a group called AVAMed, which looks at all health technologies and advocates for certain payment structures and for enhancement of certain clarification in certain payment structures. I think with the current changes, shake-up in Washington, the new administration, I guess it's still new, there's a lot of opportunity there for altering payment patterns. And I think we believe that old payment patterns are changing rapidly today. And the changes from just paying for events or for certain amounts of healthcare or delivery, let's say procedural payments, to outcomes-based payment, and really looking at more value, incorporating that into the payment structure. Huge program coming in Medicare in the next couple of years. It's a new program. We have to see how it works. We think we're extremely well positioned to navigate that. We think it's a big opportunity to get more awareness of our pain therapies, to get more coverage, to treat more patients, to help more physicians and practices treat more patients with our devices, because we think our outcomes are extremely good. We think our devices are highly cost effective. We've built a lot of evidence around that. We have experts in real world evidence who mine Medicare databases and specifically look at how our products provide value to the patients. So where that value comes in, you take a patient who today is in terrible pain, they're getting ongoing healthcare visits related to their pain with their primary doctor, with their specialist, often seeking surgical guidance, repeated imaging. They're on 3, 4, 5, 6 different medications. They may be in and out of emergency rooms. They're highly cost, they're generating huge cost to the system, and meanwhile they're in terrible pain and they're not very functional on the societal side of the equation. So you take a patient like that, and when you apply an effective therapy, let's say an Abbott spinal cord stimulator, and the patient gets their life back, goes back to work, becomes productive, and all their consumption of these other healthcare activities go down naturally because they don't need them anymore. So we roll that up and we generate cost effectiveness models, and we show that our therapies, although they're not, they're not free, but they're highly cost effective in this set of patients.
Yeah, I mean, I think a lot of people don't realize the cost of diabetes or cardiovascular disease or other diseases like chronic pain actually has over time, right? If you look at because these are chronic illnesses, the effect over time, it's expensive on a month-to-month basis, but when you add it up over 20 years, 30 years, 50 years, it's significant. Yeah. So when you're offering a solution that can cut some of that spend over time, that's where you see that huge cost saving. And that value-based care has a huge opportunity to go forward. So I love to hear that Abbott's not just investing in new technology, but also investing in ways to make it accessible to the public, doing the diligence, doing the work with the government and the payers to be able to show the cost effectiveness. That's just fantastic.
Absolutely.
So moving on from there then, one of the things that's really important, the name of our podcast is Doctors Unscripted, right? And it's called that for two reasons. One is because obviously, as you know very well, we didn't script this, like we're just having a conversation. But the other part of this is in a very real way, we're trying to solve the opioid epidemic. And so there's a pun on words there, right, of unscripted. How, in your opinion, and I know this is a big question, how can we help solve the opioid epidemic in America?
I think the U.S. has learned through a decade of exuberant opioid prescribing, where I think at the front end of the U.S. opioid experience, well-intended physicians believed that if you simply prescribe enough opioids, that will answer this kind of crazy epidemic of chronic pain that we see in 20% of the population. Doctors are too afraid to do this prescribing, and then all these patients will be well treated, and they'll get better, and healthcare costs will go down, and we'll all live happily ever after. We kind of know the end of that was different. That was not the way that ended, and it still hasn't ended. What in fact happens is that although opioids are helpful in a selected group of patients, for most patients with chronic pain, if they get relief from opioids, it's transient. Patient becomes habituated. They need increasing doses often. Yep. Sometimes they become not only habituated, but they become psychologically or physically dependent on them. Yep. They can become addicted to them because sometimes they get other feelings of euphoria from these, sometimes from the medications, and many times even in opioid experienced patients, they can overdose accidentally or in combination with other medications. And so there are a truckload of negative effects from these medications that it turns out are not that effective at treating what they were originally intended to treat. The chronic pain is not that well addressed by this. So this entire misadventure played out over about 10 to 15 years, and around 10 years ago now, maybe 11, 12 years ago, there was a recognition that we have a giant problem in the United States, that we've overprescribed opioids massively at scale. Chronic pain specialists at fault, primary care, companies that were making and marketing opioids were exuberantly marketing them, and there was plenty of fault to go around. Initial intentions were good, played out very badly. So a group of medications that have a role in advanced cancer pain, end-of-life care, suffering at end of life, were applied chronically with great mischief and misadventure, and really ripped through part of the country called Appalachia with devastating consequences for generations. Okay, so where are we today? So legislation was passed, doctors were re-educated, these medications have a significant downside, they're not that effective in chronic pain, patterns have changed, doctors are now aware we need to be careful with these medications, we need to be judicious. And by the way, we have lots of other options to treat chronic pain, which is the huge key to the story. Now, those are, so people often ask me, they're like, well, spinal cord stimulators, that's the answer. You just put that in and everybody comes off opioids and it's simple. But it's not that simple. There's so many patients on opioids. Some of them are terrific candidates for a spinal cord stimulator. Many of them are, quite frankly, are not. Yeah. It's not clear why they're on the opioids they're on, or they're on it for a syndrome that's not really responsive to stimulation, something, I don't know, fibromyalgia, or maybe a headache syndrome, or something that maybe is not amenable to a stimulator. So that's not simple, although we believe generally that better med tech approaches to treating chronic pain, things like radiofrequency ablation, a more advanced, robust use of even simple things, aggressive physical therapy, perhaps advent of revisiting of advanced chiropractic techniques, guided reanimation of patients, and I think weaning patients off medications who have a problem and maybe are overly dependent or even addicted to medications, with expert help and guidance to get patients away from those medications, and then availing them of all treatment paradigms for chronic pain that don't involve opioids. There are so many ways to treat patients that don't involve opioids now that are highly evidence-based. Neurostimulators are a terrific part of the solution
Great tool,
to this.
but it's one tool.
That's right.
Yeah. As we've done this podcast and we've had a lot of conversations with wonderful people, one of the things that seems to be a reoccurring pattern that I've seen is that one of the ways that we treat the opioid epidemic is to treat the chronic pain epidemic. But we don't talk about the chronic pain epidemic, we talk about the opioid epidemic. Try to get somebody unaddicted to opioids when they're still experiencing intense chronic pain. It's not going to work, right?
It's very difficult.
You have to have something that treats the pain, because if you just are saying we're taking away the opioid, but we're not replacing any type of pain management, the person's going to turn to the street to get something to get that back, right? And that's actually where we see a lot of opioid death, is not necessarily just from what's being prescribed, but from the fact that they're no longer getting something prescribed.
That's right.
And they have that, whether it's addiction, dependency, or pain, that's saying, I need to address this. They turn to the street, they get some fentanyl, they get something, whether it's dirty or something else like that, and then we see death through this. So I do believe that one of the things that you very eloquently brought up is we need to look at using modalities that are not opioid based to treat the pain, and whether that's neuromodulation, physical therapy, chiropractic you mentioned, like we have all of these other tools that are available to us to treat pain, and when we're doing that, and then through really great expert pain management, weaning them off of those meds as we treat the underlying root cause, you can change people's lives. You can get them back to a life where they're no longer dependent on something to, have a normal day. And in the end, that's where I feel like we're really going to see us taking our country back from that opioid epidemic.
We have some extraordinary data that is very close to being publicly available on the use of our neurostimulators at population scale in Medicare patients. And we're now able to access Medicare data, I think it's back almost 10 years, back to 2017.
That'd be awesome.
All the Medicare data. So we have thousands of patients with 10-year outcomes, almost 10-year outcomes. And Medicare, with the advent of Medicare Part D that covers medication, we're able to look very granularly at medication use. And what we find is great news. It's exactly, if you and I sat at a whiteboard and wrote out how we believe the best case would be, we think that's what's really happening. So we think when patients get advanced interventional pain care, including a spinal cord stimulator or a DRG stimulator, that about let's say approximately 75 to 85% of their medication use goes to, it goes down by about 75 to 85% pretty quickly and in a sustained fashion for 10 years. And so the good news on this is that this is that we need to publish that data, make it accessible to the public at large, to the payers, to the government, and then we need to shout it from the mountaintops.
So I love that you guys have this, because we've obviously seen this in our clinics, and the question is are other people seeing this? Right? And so the fact that there's a chance that we would be able to have this in a really strong scientific process coming out saying, hey, we've looked across all the data, whether it's a meta-analysis or whatever you guys end up doing, but having good research that shows this isn't just you, this is across the board. I do think that neuromodulation is such an incredible tool for fighting the opioid epidemic, because it's an incredible tool for fighting chronic pain, right?
Yes.
And so we've seen those results, and that's one of the reasons why I wanted to have you on the podcast, obviously, is we've had other great conversations in the past, but just what Abbott's doing in the neuromodulation space, I feel like you're advancing both healthcare as well as access in a really strong way. And I think that as we do that, when we have good physicians around the country that are trying to tackle this very big issue that's taking lives, the opioid epidemic, but also just treating chronic pain, I feel like not only can we save lives, but we can really give people back their lives. And there's a difference for that, right? So saving lives is, trying to get people off those opioids. But when I say like giving people back their lives, it's when that person's in pain, when mom has to sit in bed all day long and can't play with the kids and can't go out and can't cook dinner, that whole, not just that household's disrupted, but everyone in her community is disrupted. And when you can go and say, we can help you to get out of that pain, and now it's like, hey, I can be an active member of the family, an active member of the community, this is one of the most amazing ways we can actually help our community. So I love that through the work that we're trying to do, we can really try to lift communities into a place where life is better.
Well said. It's hard for me to build on that. But each patient that you treat and your team and your physicians treat and our therapies treat is part of a spider web of their community. So each of those nodes in that community, as they get lifted and as they become productive and engaged and back to life, all of the success that each of those patients have ripples, as you said, through their children, through their families, through their communities, through their coworkers, through their colleagues. And so the reason to believe and the reason to be excited and enthusiastic about the future application of this technology, and that we're right now today, we think we're just scratching the surface of this problem. I mean, we're excited about what we've done to date, but we think there's a huge reason to believe and a reason that we're going to continue to grow this and apply and find more patients in need of these therapies.
Well, I would say, love the work that you guys are doing at Abbott. I love what you're doing there, going out educating and helping doctors to actually learn how to use this technology better. So thank you so much for the work that you're doing. Thank you for coming on the podcast today. It's been an absolute pleasure to be able to explore this topic a little more with you, and ultimately to give hope maybe to some people that are out there in pain, knowing that there are options for them and that possibly neuromodulation might be one of them. So thank you so much for coming on.
My pleasure. Thank you, Dr. Thompson.
Absolutely.